Welcome to the Passionate Dentist Podcast YouTube channel. I'm your host, Dr. B, and here are some tips and tricks that you can take to your practices on Monday. One of my favorite things to do in dentistry is to make dentistry more predictable. And basically, I want to see the results before they are done, especially for large cases. And the best way to do that is to use something called diagnostic wax-ups. Notice they're called diagnostic wax-ups. And we're going to talk a little bit about that in the little video a little later. But what I want to talk a little bit about right now is just understand that diagnostic wax-ups should be done for all full arch cases. Even if it's relatively predictable and easy, it's good to take models, photographs, send them off to the lab with specific instructions and have them do a diagnostic wax-up with your instructions on it. Very, very important. But it's not just that. Any case that involves just a few teeth where you're going to change the vertical dimension should have a diagnostic wax-up. I go in so far as if it's a patient that requires 6 upper anteriors, just veneer cases, I still do a diagnostic wax-up. If it's a 4-unit or 5-unit case, even if it's in the posterior, I still do a diagnostic wax-up. And I'll go through a little bit more about why in just a second. But here's a case that I'm going to review in a few minutes in more detail and up-close videos and images. But this is a fantastic case where it does involve surgery. It does involve anterior reconstruction, posterior reconstruction, and vertical dimension. This is a fantastic case for me to showcase, just so you understand why it's so important. First of all, when it comes to preparation, luck favors the prepared. And the best way to prepare for anything in dentistry, especially large cases like this, is to do a diagnostic wax-up. Please do that. It also allows you to solve your problems before you touch the patient, because you will basically have to go in there and do all of your preparations on the model before you actually touch the patient. You figure out your problems there. Sometimes you can actually have the lab do the preparations for you, and that's what happened in this case, if you trust your lab. But in the beginning, I used to prepare all my own teeth and then send it off to the lab and say, do it like this, and see where the problems come up. But once I have the diagnostic wax-up, this is beautiful right here, because the patient will use their wax-up as a way to see what their final is going to be, because I'm going to use the wax-up to make them their provisionals using the wax-up. Meaning, whatever the wax-up is going to look like, that's what they're going to have in their mouth as their provisionals. So they get to test drive their teeth before we actually put porcelain and stuff like that in there. The logic in the past that I've heard is saying, don't make your temporaries very, very pretty, so the patient doesn't expect too much or something like that. I've found that that's a very, very antiquated logic that doesn't apply to 2016. Make the best, absolute best temporaries and provisionals you can make, so that the patient can see what it's going to look and feel like before you finish it, and there's no drum roll at the end of the appointment. Everybody knows what it's going to look and feel like. Okay? Now, one thing I also do is I also charge the patient for these wax-ups, but I also say, oh, by the way, these wax-ups are going to cost about $500, $1,000, and so forth. I say, I need you to pay that. You own it afterwards. If you go someplace else, you can take it with you and so forth. But if you choose to go through this treatment plan, I'll apply it to your final cost. What this does is, one, it shows me how serious the patients are. Two, it also shows the patient that I'm planning and designing and all this other stuff. And when you charge a case like this $35,000 or $40,000, they understand that there's all this planning and designing and so forth that goes into the program. So if the patient says, no, I'm not going to pay for it, you should just charge me at the end. At that point, I know they may not be serious. Okay, so you get to rule out some of these patients that may or may not be very serious about this. Last but not least, I want to talk about is the actual prescription. What you don't do is take this case, send it to the lab, and say, give me a diagnostic wax-up. Because the patient has a lot more than just a model with teeth on it. They have, you've taken photographs, you've spoken with them, you've reviewed the photographs, you've looked at the occlusion, you've looked at their medical history, you've looked at their chart and dental, each individual tooth charting, you've looked at the mobility, the bleeding, you've looked at all this other stuff. The lab can't see these things, so you have to give them very, very specific instructions of what needs to be done. In this case, I actually sent this to the periodontist, the model, before the actual wax up, and I said, I need to trim the tissue to create length. Can you please mark it with a pencil? It took him probably about 5 minutes to do it, maybe even 30 seconds, but at least I got the periodontist involved. And the patient knows this, that the periodontist has seen this, the lab tech has seen this, I have seen this, and the patient knows all about the stuff. So everybody's informed, and the patient starts saying, okay, well, maybe that's why it costs $40,000 or $35 or $50, depends how much you charge for these cases. And so just understand that when it's time to send it to the lab, you need a lot more instructions than just give me a diagnostic wax up, all upper teeth, lower anterior teeth. You need more than that. So let's move on to the actual slideshow that shows all the details about how I did this and why I did this, and I'll catch you at the end. So here's the case I was talking about earlier. Now this is the patient actually hasn't given me permission to show his face, so I can talk a little bit about his model, but that's about as much as I can reveal. So you can see the case mounted on an articulator, and the articulator was set up using a face bow. So this is about as accurate as we can get it. Here's a slight close-up of it. You can start seeing how his lower jaw is significantly smaller than his upper jaw. He's basically class 2. He's severe class 2, and he has a very deep bite. I'm going to see a little bit more about this. Even a better view here, you can start seeing all the detail. Up close, you can start seeing how much wear he has. His canines, in this image right here, his upper left canine is worn. He has severe wear. And we're going to see how we can use a wax up to really help this case. Upper right canine is also quite worn, but not as bad. But you can see the severity of his class 2 occlusion. You can see the bite in this picture. It looks like his lower anteriors are not there, and he's directly biting on his lower gingiva. This is his upper full arch. Now the interesting thing is when you look at this case is you realize that it's not terribly worn in the posterior area. Yeah, he has some wear, but it's not horrible. It's not compared to his upper anteriors. It's not as bad. And you can see that he's worn his upper anterior, especially his upper left central incisor, is worn about halfway down. The incisal edge, the width of the incisal edge, the whole shelf here, is about 5 millimeters wide. So that's about halfway down to the entire length of the clinical crown. Here's a good image of lower anteriors. Isn't that incredible? And so all it is just tissue with little white tooth parts in there. They're not even white, they're kind of yellow. Here's an up-close image of it. Now you can look at this and you can say, let's just extract all of these teeth, put implants. That is an option. But because of various reasons, which I'll talk about in a few minutes, while we're reviewing the actual wax up, I'll tell you why we chose not to do that. But in this case, you can see the severity of his wear, canines and his lower anteriors. Here's a better one. Incredible. But again, look at the posteriors and you'll see that he does have wear, but not horrible like the anteriors. He just likes to rub his anterior teeth together somehow. He has some kind of a biofeedback. And I've seen this with people who have severe class 2 malocclusion. Here's another image from the other side. So what I did was, I sent this case to the lab with specific instructions, and at the end of this video you'll actually see the prescription that I wrote to the lab. I took a photograph of it explaining these things. So going back to this image right here, you can tell that his upper anteriors have super-erupted and his lower anteriors have super-erupted, but his plane of occlusion isn't all that bad posteriorly, not counting the anteriors. And so if we were to open this vertical, drop the upper posterior teeth down a little bit, raise the upper anterior teeth, basically do gingivectomy, we should have a much better plane of occlusion. And do the same thing, do some gingivectomy and osteosurgery on the lower anteriors also. That will create a much better plane of occlusion, and that's what we're trying to do. All these things can be figured out in the diagnostic phase. So coming back to this image, we can see that we've lengthened the upper anterior teeth, but I didn't lengthen them down. I didn't lengthen them incisally, I lengthened them gingivally. To do that, we needed to tell the lab tech to go ahead and remove some of the tissues to simulate gum surgery. Of course, the lab tech is not trained to do gum surgery. So one of the things I did was I sent this case to the periodontist, and I said, what kind of gum surgery do you think we should do on this case? What should we be expecting? And all he did was he took a pencil and kind of drew it out on the model. And the lab tech just went in there and ground away some of that stone, just to get an idea. And she did the exact same thing on the lower anteriors also. So we adjusted the plane of occlusion a little bit. The posterior maxillaries were dropped down, so we opened the vertical a little bit. So in this case, the upper anteriors are slightly longer gingivally, posteriors are slightly longer occlusally, and that equaled out the plane. This is an image from the right side, same thing. And you can see we actually have teeth on the lower anteriors now. Again, this was all done, marked by the periodontist. And to adjust the lower plane of occlusion, all we had to do was lengthen again the teeth gingivally, not incisally, because those teeth were already in contact. By opening the vertical by just 1 millimeter or 2, we create what we call as a convenience space. I'm not a big believer in opening up verticals 4 to 5 millimeters. I don't do that at all. Just 1 millimeter or 2, maybe 2 being max, by the way, just for convenience. And you can see that the lower anteriors are not just 2 millimeters long, they're much longer. That's because we lengthened them gingivally. Here's another image of the anteriors, from the anterior. Now, one of the things that the diagnostic wax-up does is it's diagnostic. It's not just a wax-up that you send to the lab and say, make me crowns. It's diagnostic. You learn a lot about the occlusion. You learn a lot about the patient's bite pattern, what's going to end up in the diagnosis of the wax-up. And so these, in this case, the wax-up was actually removable. You can kind of see what appears to be a crack in the upper, between the central incisors, but it's not. It's just a separation. So that the upper right anterior segment can be removed from the model separately from the upper left. Actually, all the lower anteriors can be removed also. Upper posteriors and right and left also can be removed from the model. This gives me an idea of how much room I have, how much vertical, how much separation. In hindsight, just looking at this case is, by the way, I haven't completed this yet, but just looking at this case, I've pretty much decided that I need to do occlusal and facial preparations on upper right and upper left premolars. We need to bring those premolars out a little bit more so that the posterior teeth don't disappear behind the anterior teeth or the canine eminences. And these things cannot be figured out by just looking at a pre-op model that we saw earlier. You can't make provisionals using those. You can't predict it. This has to be done on a wax-up. Looking on the left side, and what I'm doing on this image right here is I'm starting to move the jaw a little laterally just to see what kind of guidance I have. And this is canine guidance on the left side. I'm also looking on the right side. And then I open the articulator and just look at the entire upper jaw, the upper arch altogether. And this confirms my opinion that we need to bring out those premolars a little bit to create a better U-shaped pattern. At this point in this image, it appears that the upper arch is in a hourglass shape, and we don't want that. We're looking at the lower anteriors now, and we can see that everything's in a pretty nice arch form. Yes, those lower anteriors are a little short and fat facial-lingually, but it doesn't matter. He actually does have a pretty good incisal edge. They're short. We don't want to take away so much tissue and so much bone that the tooth becomes terribly loose. We want to take just enough to make it to create a what we call as an occlusal plane. In this image right here, I extend the canine guidance all the way to the right side just to make sure I have good clearance in the back. Now, just because you want good clearance in the back does not mean you make the canines very, very steep. Actually, you want to make it not very steep. You want to make it so that it just misses the posterior teeth. This is almost a little too steep for my taste. And I'll figure this problem out towards the end, in the provisional stage. Because if it's too steep, it's going to lock his jaw, and he might actually brux again and break the porcelain. And this is the left lateral function, and you can see again the posteriors. So you can see in the premolar area and the molar area that the teeth barely miss, which is exactly what you want in canine guidance. And this is protrusive function. When the patient protrudes forward, you can see a nice edge-to-edge. Posterior are missing, but not horribly. This is from the other side. We have good anterior guidance. This is the actual prescription I wrote to my lab tech. Now, one of the things I've seen many times before is people send their cases to lab techs and say, wax up all maxillary teeth, crowns in the anteriors, onlays in the posteriors, wax up all lower anterior teeth, and that's it. That's all they say. The problem is they don't know the patient, they don't know their smile line, they don't know their speech pattern, they don't know any of these things. You need to see these things in the photographic series, which is also another video that I'll have one day. Once you have the photographic series and you've talked with the patient, that's when you decide whether you're going to lengthen the teeth gingivally or incisally, and so forth. And you need to let the lab tech know all of these things. So if you look at this prescription, you'll see that it has all this detail on it. And actually, in this case, my lab tech, she picked up the phone and called me and asked me questions about this, saying, well, why do you want to do this and why do you want to do that? And that's the kind of relationship we want to have with your lab tech, is when he or she can call you and ask you questions about these things instead of just make the wax up and send them to you. Hopefully it's okay. So I hope you use these wax ups for your benefit, because whenever I do any kind of cases that involve 6 or more teeth, especially if it's in the anterior, I almost always do a wax up, and I charge them to the patient, and that works very well.